In particular, the clinical progression of migraine depends first on frequency of headache experience and the individual's reaction to that headache, so that there's a biologic phenomena and, yes, there is a limbic phenomena, the memory system and the implications of pain, which tie into basically our cultural beliefs. So it is a complex combination of biology, the body, and the mind, so that for the patient who is most difficult in one's practice, one rarely gets a really satisfactory response by just manipulating the biology through drug therapy, rarely through needle therapy. But you really have to understand that individual, who they are, and what they want, and work with them to change behaviors and thought patterns. So it's really, in a sense, getting to know what their concerns are beyond just get my headache better. What is their life all about? And that I call the art of medicine. So my talk was a little bit about science and a lot about employing the art of medicine, which is a lot about the power a practitioner has in how they communicate with an individual. Yeah, the cyclone of headache is sort of a way for the practitioner to realize where they're at if they really review the issues within the cyclone. If you can get a patient early enough in the process when they have 4 or 5 headache days, they're not in the cyclone. But as they become anxious about their next headache, as they have a memory about the last headache they suffered, as they take a drug a little quicker or maybe even preemptively take a medicine, which we may encourage them to do, as they incorporate other things that happen in their life, they're a little over-scheduled, they aren't having enough time to eat, you start to get into the cyclone issues. And those are sleep disturbances, not enough time spent exercising, a little overuse of medications, acute, trouble tolerating the preventatives. You start to see within this framework anxiety and mood, which they, of course, attribute to the pain and not an independent phenomena in any way. And these all just become worse and worse, so you spiral, in this case, down in disability, and often spiral up in the use of acute therapies. And it's just a way of trying to get practitioners to realize the complexity of the disorder and that there's not one simple solution here. Well, there's a controversy between patent foraminal valley, PFO, and stroke, and there's a controversy between PFO and migraine. Yeah, we all have a PFO in utero. We all do. Roughly 20% of us have a PFO in adulthood. Somewhere between 20 and 25% of us have this patent foraminal valley if we're a migrainer without aura, and somewhere between 40 and 49% based on studies if you're a migrainer with aura. So the particular group of interest is migraineurs with aura who are at increased risk of stroke, especially under age 45. And could their whole disorder in some way be influenced by this hole in their heart? And the answer right now is unclear. And it's controversial about even looking for it. So I encourage anyone who makes this connection that they really enter this individual into one of the research studies. There's at least 3 going on right now. And don't rush off to do any PFO closure because, in fact, we may learn that it's not the right thing to do.